let's take a different marker. You have a patient who gets EGFR, ALK, and ROS, and BRAF. Those are the ones that are most indicated by molecular testing. Those are negative, but the patient ends up having broader testing and is found to have a HER2 mutation, which is in the EGFR family, but it's a different member of that class and not the same as the EGFR we talk about. We have HER2 directed therapies that have some modest data. What is your interpretation of the clinical significance of a HER2 mutation in terms of what you might do and when you would use that information? Would it be a first line? Would it be a fourth line? Where would that fall when you see this in your results from the next generation sequencing panel? Suki.
Yeah, so in terms of HER2, if we haven't started first line therapy yet, I would probably incorporate it into my decision making, which I'll talk about. But I sort of view HER2 mutation similarly as a patient who has an EGFR mutation or a patient who has an ALK rearrangement. You know, these are frequently driver mutations associated with never smoking or light smoking.
Right.
Lung cancers. And of course, for a clinical trial setting, like a lot of these combination chemotherapy and immunotherapy studies, patients with EGFR and ALK were not included. But I think probably these kind of HER2 mutations and potentially other drivers similar to that probably are in some ways similar to those tumor types. So I don't know exactly how well we know combination chemotherapy plus immunotherapy works up front for these patients. So we just have a discussion, you know, about it. If they were PD-L1 high, for example, and you technically have the option for single agent immunotherapy, I personally would not be comfortable with that. But, you know, in talking about combination chemotherapy plus immunotherapy, it is a discussion about how much immunotherapy is truly adding. I think we don't know.
Yeah, I would say these are patients who would be eligible for all of the trials
Absolutely.
that were with chemo plus immunotherapy.
But we just don't know.
Jonathan, how about your view on how you would use this information?
I mean, it's potentially actionable. I mean, I think what Jack's bringing up is, you know, also what line of therapy. I mean, we have multiple, you know, there's multiple clinical trials targeting HER2 exon 20 insertions, poziotinib, paratinib, TAC-788. There's numbers. So you know, at UC Davis, we offer them a clinical trial. We had the poziotinib study in first line as well. So you know, that's something that we discuss.
What about
but
the
I
people
think
who don't have
for the people that don't have a trial, I agree with Suki. PD-L1 high, I would not give, even though they would have been eligible for the Keynote 24 trial that looked at Keytruda versus chemotherapy. I would not do immunotherapy alone. I think that's definitely a no-go. I think you know, they probably would have you know, you would anticipate similar to EGFR, they wouldn't have the same benefit to immunotherapy. But I think it's a discussion with the patient whether you do add the IO to chemotherapy or not in that situation. We just don't know.
I think that we know a lot less than we do about the other targets. And to me, I think there's a difference in that with EGFR and ALK, we know that these are extremely effective targeted therapies. And with HER2, we have treatments that have marginal utility. So worth considering for later, but to me, they don't leapfrog over the better established therapies that these patients would be eligible for in these trials.
I agree. And outside of a trial, I mean, you have, you know, there's afatinib, which gets EGFR and HER2, response rates of about, I think, 15% or so. There's the antibody drug conjugate, that's the TDM1 that's approved in breast cancer, that has a higher response rate, I think on the order of about 40%, and progression-free survival, I think 5 months or so. Yep. So, you know, those are options, but I would that would be second line. I mean, I agree, that would be second line. I think my concern is that
you'd really want to use the treatments that are well established before jumping in with
Yeah.
modest phase 2 data
Correct,
that are good enough to try at some point, but not replace standards.
And I think, I kind of think about it similar to, like, if you look at the drug development, take, for example, RET fusion lung cancer, where, a couple years ago, there was kind of these multi-targeted agents that some got a bit of RET, like cabozantinib, so response rates were about 30% or so. And then these newer generation drugs came along, like selpercatinib, which is the LUXO-292, the blue 6-7 drug, and now response rates are like 60% or so, and,
Right.
and progression-free survival and all, looks phenomenal. I think, like, for selpercatinib, like over 18 months. And so, HER2 is actionable. We need a drug with manageable side effects that really, that can
Hits it
target
well.
hits it well.
Mhm.
Thank you both very much for your time. Really appreciate it.
Thank you.
Thank you.